Welcome to Good Sex at NYU, a podcast about sex, relationships, health, and mental health in a sex-positive space. So if you're looking for sometimes serious, sometimes funny, and always sex-positive discussions, then you're in the right place. I'm Danielle Elliman, Associate Director of Sexual and Relationship Respect Services at Counseling and Wellness Services. I use she, her pronouns.
And I am April Fellers, a nurse and sexual health educator at the Student Health Center. I also use she, her pronouns. We are two white, cisgender, heterosexual, female-identifying clinicians, one with a medical background and the other with mental health experience, who seek to create a space that is inclusive of all identities, backgrounds, and perspectives. Today on Good Sex at NYU, we are joined by our colleague, Dr. S., who is a medical provider on our gender and sexuality team. Dr. S. has over 15 years as a board-certified family physician and has spent many of those years providing comprehensive care, including gender-affirming care. Thank you so much for being with us,
Thank you for being
Dr.
here.
S.
Yeah, thanks for having me. I'm excited.
Yeah. I, April, am also on the gender and sexuality team at the Student Health Center, and so we've gotten to work together on some of these cases, and I've just learned so much from you and all the other people on this team, and so I'm glad to be able to have this conversation today and to just let people know a little bit more about the care that we have available at the Student Health Center, and just to kind of provide some more information to people that may not know about this topic very much. So,
yeah, I'm sitting here nodding, realizing that it's a podcast. Yes, I agree.
With that said, because the topic of gender and sexuality and specifically transgender care is a very political topic right now, and as we know, there's lots of bills all over the country trying to be put in place to prevent transgender medical care being available specifically to youth. You know, we do want to just mention that this is an ever-evolving topic, right? The information that we're sharing today is current as of March 2024. It's currently based on the 8th edition of the WPATH Standards of Care. WPATH is the World Professional Association for Transgender Health. And medical gender care is a newer specialty, relatively speaking, and so the guidelines and the recommendations are continually evolving. Dr. S., if you know when the first edition was created?
I don't know when the first one was, but the 8th edition came out in October of 2022, and it really is exceptionally different, and I love it, and I refer all my patients to it because it is an incredibly more comprehensive and evidence-based approach to this kind of care. It has a bunch of citations and reasonings about why they have the recommendations that they have.
And it took us 8 editions to get that far.
Yes.
I'm sure there's farther that we can go.
Exactly.
Good to have a really comprehensive place to refer to.
Yeah. So that's just evidence that it's always evolving. And so what's true today might not be true a few months from now, a few years from now. And that goes for language that we're going to use today as well, which is ever evolving. And so we will try to use language that we know is current, but that also, don't come at us in a couple of years if things have changed.
Yeah. And I also want to just add to that the medical community has been really lagging in this field, and many of the terms are going to change and should change. And so I'm not personally comfortable with the term gender dysphoria. I like gender incongruence, but I might say gender dysphoria during this talk.
Because that's the current medical term. I think that's
right.
That's
just like elective surgery means non-emergent surgery. It doesn't mean that you don't need the surgery.
Mm-hmm. That's a good point. Yeah. And somebody in the medical, I don't think I knew that even as a nurse.
Yeah. It can come across as like, oh, why are you calling that elective? And I really need that to save my life. Well, it's not today that you need it. The OR wants to schedule it in a month.
Yeah. When I think of elective, I think, oh, that's like some kind of plastic surgery. Like you don't really need it. It's just like, for fun.
Yeah, exactly.
Yeah. The other thing I did want to mention is, because we are going to be talking about medical care today, but it's really important to note that somebody who's gender identity is transgender or non-binary, gender non-conforming, gender expansive, any of these terms, they are in no way exactly like any other person who has the same gender identity as them. So some people may have similar treatment plans, but they also may not. And no one should ever make any assumptions about what treatment somebody wants. And that's why it's important that the medical gender care is individualized and tailored to each person's specific desires and goals for themselves. And I think that that's one of the biggest things that we've been trying to focus on at the health center, and just really individualizing care and really talking to students about what they need and want, as opposed to what we as the medical establishment think that they need or want.
Absolutely.
And I think that's pretty consistent with what we've had a theme in the podcast as well, being seen as the individual. Yes, sometimes it's helpful to have like some of these terms or some of these, diagnoses, but it's also important to really sort of be seen as a human, and like what works for us may not work for the next person. So I really like that, we're including that. Dr. S., can you share with us some of the ways in which you became interested in specializing in medical gender care, and what continues to motivate you to do this work?
I love this work. I've always been interested in providing care to those that have less access to care. I spent most of my career at federally qualified community health centers, which are federally funded centers that are sort of the safety net in the U.S. for people that don't have insurance or have limited insurance or access to care. And at those places, I always, as a family doctor, I always valued full spectrum primary care, and that includes sexual health, reproductive health, and gender care. When I came to NYU, I was really excited to meet like-minded providers who are committed to holistic care, and I was excited to join the gender team and learn from the providers who are already doing this care in a dedicated team at the Student Health Center. I love that there's extra support from psychiatry, social work, and all the departments. I mean, it's a lovely environment that it almost is an alternate universe when it comes to health provisions, because there's a ton of resources and support.
I don't know if this is important to note, our whole podcast is about the Student Health Center, but specifically for this topic, just to let people know that we're talking specifically about gender care at the Student Health Center and not NYU Langone or any other NYU place. This is specifically the NYU Student Health Center.
Yeah, I mean, I think it might be helpful to continue to make that clarification, just because it's great that we have such great resources at NYU, but also there's like the comparative, like when you go outside of, what does that look like? So if we have any knowledge, like we might, reference that, this is what it might look like if you were to go outside of NYU.
Accessibility is a real issue for gender care outside of the Student Health Center. I think other hospitals will have one or two providers that will do gender-affirming care. They'll have a great surgery team, but the primary care, the holistic care is not as available because it's just not as profitable. And so I really appreciate the commitment that the university has for its students.
Well, since I'm not the person on the gender and sexuality team, maybe we could just go over some of the basic definitions before we sort of continue through the conversation.
Sure. Yeah. So when you prompted me with this question before the meeting, I really am a terrible person with words. My parents are both artists. I'm a very sort of nonlinear thinker. So I went ahead and I looked up the Associated Press style book for my definitions. Cisgender is a person whose gender identity aligns with the sex assigned to them at birth. Transgender is a transgender person, is someone who identifies with a gender other than the one that was assigned to them at birth. And so we use these terms in medicine called AFAB, AMAB, assigned female at birth, assigned male at birth. It's become a political word that's rife with layers of things, but that's literally what it means. When you brought up these definitions, I wanted to add something about intersex and people with variations in sex characteristics. They're actually a lot more common than we appreciate, and a lot of people don't discuss it or appreciate it. So they're people born with chromosomal, gonadal, hormonal, and or anatomical characteristics that may not align with one another and or fall outside what is typically classified as male or female. And if it's okay, I'd like to just read, and you all can decide if this is relevant or not, of what the Intersex Society of North America defines as intersex, because I think it really brings to the fore that gender is a spectrum, and assigning a child at birth a certain gender is a medical thing that we do, and there are many layers to that we should probably appreciate more.
I was going to say, I think that's like what you just said, right? More so now that blood work is being done before babies are being born. And so you can generally, if blood work is done, you can see the chromosomes of a baby. Yeah. But really, when we were all born, The way that they knew that we were assigned female at birth was because they looked at our genitals and that's what they saw. And that's really, like what you're saying, is that there's so much more complexity to that.
Correct.
And nowadays we can get more nuance with blood work and testing chromosomes and whatnot.
And we still might not get the right answer.
Of course.
And that's where I think the intersex movement has really brought our attention to the fact that doctors maybe shouldn't be determining, and humans should determine themselves what their gender is rather than their genital presentation, defining
just
everything.
Looking at like the sex, right? And I think sometimes we still see those like gender reveal parties, and it's like gender.
You're celebrating a baby's genitals.
Yeah, that's it. Right? And I feel like that's just really weird. Right? Like, you're interested in what genitals my baby has?
Mm-hmm. Yeah.
You know, that's it. Because gender is a construct that society has really placed on us. Chromosomes and all these other things are what really sort of tell us. Hormones tell us what.
And that's still just the sex.
Exactly.
Right.
That's just the sex.
Yeah. Right. And I think, I'm sure you guys had Chris Wood on here before. He's much better with these definitions. He's fantastic. He does a really great course on the differences between gender, sex, gender identity, and sexuality, and how they're all very separate. So what our intersex colleagues have said is a general term used for a variety of conditions in which a person is born with a reproductive or sexual anatomy that doesn't seem to fit the typical definition of female or male. For example, a person might be born appearing to be a female on the outside but mostly have male typical anatomy on the inside. Or a person may be born with genitals that seem to be in between the usual female and male types. For example, a girl may be born with a noticeably large clitoris or lacking a vaginal opening, or a boy may be born with a noticeably small penis or with a scrotum that is divided so that it is formed more like a labia. Or a person may be born with mosaic genetics so that some of their cells have XX chromosomes and some have XY. Though we speak of intersex as an inborn condition, intersex anatomy doesn't always show up at birth. Sometimes a person isn't found to have intersex anatomy until she or he reaches the age of puberty, or finds himself an infernal adult, or dies of old age and is autopsied. Some people live and die with intersex anatomy without anyone, including themselves, ever knowing. Which variations of sexual anatomy count as intersex? In practice, different people have different answers to that question. That's not surprising because intersex isn't a discrete or natural category. What does this mean? Intersex is a socially constructed category that reflects real biological variation. To better explain this, we can liken the sex spectrum to the color spectrum. I think Neil deGrasse Tyson does a great talk about stars and spectrums, and the universe and spectrums. There's no question that in nature there are different wavelengths that translate into colors, and most of us see red, or blue, orange, yellow. But the decision to distinguish, say, between orange and red-orange is made only when we need it, like when we're asking for a particular paint color. Sometimes social necessity leads us to make color distinctions that otherwise would seem incorrect or irrational, as, for instance, when we call certain people black or white, when they're not especially black or white as we would otherwise use the terms. In the same way, nature presents us with sex anatomy spectrums: breasts, penises, clitorises, scrotums, labia, gonads. All of these vary in size and shape and morphology. So-called sex chromosomes can vary quite a bit too. But in human cultures, sex categories get simplified into male, female, and sometimes intersex in order to simplify social interactions, express what we know and feel, and maintain order. So nature doesn't decide where the category of male ends and the category of intersex begins, or where the category of intersex ends and the category of female begins. Humans decide. Humans, typically today doctors, decide how small a penis has to be, or how unusual a combination of parts has to be before it counts as intersex. Humans decide whether a person with XXY chromosomes or XY chromosomes and androgen insensitivity will count as intersex. In our work, we find that doctors' opinions about what should count as intersex vary substantially. Some think you have to have quote-unquote ambiguous genitalia to count as intersex, even if your inside is mostly of one sex and your outside is mostly of another. Some think your brain has to be exposed to an unusual mix of hormones prenatally to count as intersex, so that even if you're born with atypical genitalia, you're not intersex unless your brain experienced an atypical development. And some think you have to have both ovarian and testicular tissue to count as intersex. This is my favorite part, and then I'm going to stop lecturing. Rather than trying to play a semantic game that never ends. So I feel like we're going to do some semantics now, but it can never end. We at ISNA take a pragmatic approach to the question of who counts as intersex. We work to build a world free of shame, secrecy, and unwanted genital surgeries for anyone born with what someone believes to be non-standard sexual anatomy. So, I think this goes back to like our original view of gender in the 60s, 70s, even before that, if someone was born with a small penis, you change it to a vagina, raise the kid as a female, and they're going to be female. And this obsession with this old school way of how to define gender still persists to this day, even though we know that that's incorrect. And we've seen that in cases where people raised as a different gender than what they are don't just magically become that gender.
And I think this is a great place to bring up Emily Nagoski in her book, Come As You Are. She talks about the biology of creating genitals and sex characteristics and how every single person started as a single cell.
Correct.
An egg and a sperm meeting and
becoming a single cell.
And then as we divide and as things develop, as you are a fetus, then every single person, whether you have a uterus and a vulva or a penis and a scrotum, they all started as the same tissue and then they grow into different things, right?
Correct.
And I don't think I did not know that until I read her book.
Yeah.
And I am a nurse, and we've all had varying degrees of sex ed throughout our lives, and that's just not told. And I think that is like, if you just think of all of the other differences that we have, earlobes attached or not, people that have web fingers or not, like all the other differences that people just don't think about in the day to day, the same thing happens to genitals and to internal and external structures. And I think that they grow differently, and I agree that it's not our place to decide who's our right or not right.
Yeah. And I'll say too that this newer generation of students, in my personal experience, I don't know if this is in any way verifiable or true, but I think there's a lot more focus on gender presentation outwardly rather than a concern about genitals. And I think we as a group of healthcare advocates, I think could use to promote that idea.
That's an interesting point.
Yeah. I do also think that we need to unpack more of our generation, I guess, than the younger students, because I think some of those people who are making those policies, who are providing services and care, still bring to the table a lot of these very old norms. And even if we're more aware, I think we still sort of are, it's sort of seeping into us, and we need to unpack some of that.
And I to that point, and I could just go on forever, so we're never going to leave this podcast. But I've done family meetings with some of my students who agree and think that me speaking to their parents will be beneficial and helpful. And what I realized is my Gen X generation, that's a lot of the moms that have students at NYU now, really internalize this idea that testosterone is the reason for rape culture. And so if their child wants to go on testosterone, why would they possibly want that? And it's not something that's in the language of the students. And so I've had these really interesting conversations with the students trying to explain, we had these ideas in the 90s that if you wore a short skirt and you provoked these uncontrollable testosterone-ridden boys, it was our fault.
Yeah. Well, that's a protective factor, right?
Yeah.
I think a lot of the work that I do really is around what are the underlying root causes. And if we could just educate them a little bit about oppression and how that is really the reason why rape culture and toxic masculinity are the reason, not hormones, not testosterone, right? It's really, how do we stay in control?
Yeah.
Right? Like if I don't wear that short skirt and if I don't provoke the male testosterone, then I will stay safe.
Yeah.
Right? So it's a safety measure for,
I think there's some really sort of biased research that went in the 1980s on precocious puberty and testosterone causing deviant behavior too, that I think really deserves some re-examining.
That's interesting. Yeah. And we've heard from another guest on this podcast that some of the earlier media depictions of trans masc folks who started testosterone was that they became aggressive or they became angry. And so I think that just really trying to squash those narratives and
prevent misinformation and present facts. Exactly.
Yeah. Right. And the fact being that I'm assuming, and you all can tell me if this is true, that taking testosterone does have an impact.
Absolutely.
It changes some behaviors, but it doesn't mean that you're not in control, that you don't have the capacity to like emotion regulate, that you don't still have
correct,
the ability to make decisions on your own. Testosterone isn't making that decision for you.
Right. Yeah. So let's keep going through our little semantics discussion. So a non-binary person is somebody who identifies outside of the gender binary by seeing themselves as neither a man nor a woman. Personal love for this, and I'm seeing so many more non-binary presentations in my students, and I just think it's fantastic.
I also just want to name, I don't know how you all feel. I feel like we're maybe of a similar generation, but I'm wondering like how I would have felt or how I would be different if I had had some of these definitions and known some of this more when I was younger. Yeah. Like I'm so glad that, there is more of this range, because I feel like I would probably be a little bit, different presenting.
Oh, 100%. I think I'm a very masculine woman. And so when I joke about that with my trans feminine patients that like, you want to take progesterone? I freaking hated when I was pregnant and had extra progesterone, but good for you. You're enjoying this. I never enjoyed that. And, April, you're back from delivering a baby. It's really humbling to go through a pregnancy and to feel that the changes in your body, your mind, everything, thanks to hormones.
Yeah. And this is a topic for a different discussion, but we should not ever force anybody to go through that. It's not
correct.
Awesome. I did not like being pregnant.
It's really hard. It's really hard.
But I just think all these definitions are really helpful and important. I know it's sort of semantics and we're just trying to like...
No.
I feel like it's really helpful.
So we're almost through them. So masculizing is to induce male physiologic characteristics and feminizing is to induce female physiological characteristics.
Like Danielle said, I think that it's helpful to bring those into the conversation and to realize that it's more than just hormones and I'm a girl and want to become a boy, or I'm a boy and want to become a girl.
Absolutely.
Like it's a much more layered conversation, and I think that's not talked about in a lot of the politics of gender care.
Yes.
So we know that you're not a surgeon, so we don't need to go through all of the specifics, but you did mention all of the major surgeries that insurance does cover.
Sure.
Can we talk about some of those?
Sure. Yeah, I wrote a whole list. Even this goes to the way medical professionals use terms. I was at a conference at Fenway/Harvard, and people were talking about no-depth vaginoplasty. And this amazing intersex advocate goes, that's a vulvoplasty.
Yep. I was thinking the exact same thing as you said that. I was like,
no depth. That's a vulvoplasty. So vulvoplasty is an option. Vaginoplasty is an option. Phalloplasty, scrotoplasty. So,
can you describe some of these? Because as a non-medical person, I'm like,
vulva is the outside genitals. I try to get my daughters to call it a vulva, but everyone calls it a vagina. But your outside genitals.
That is like a pet peeve of mine.
Well, there's a joke about my mom's Volvo has hair on it when they're talking about cars. So vulvoplasty is taking the scrotum and creating labia and mons and all the good things and clitoris. Vaginoplasty is either taking skin or peritoneal tissue or intestinal tissue and creating a vagina, but also using the inversion of the penis and scrotum. Phalloplasty is creating a new penis. Scrotoplasty is creating scrotum. And they use testicular implants for that. I think I'm pronouncing this right. Metoidioplasty is where, your clitoris gets larger as you're on testosterone. And after it gets to a certain size, you can have this surgery where you get a release of the ligaments that hold your clitoris back and may or may not have urethral lengthening with that so that you can actually have a phallus or penis without the full phalloplasty. Facial feminization is a surgery that's done to remove secondary characteristics on the face. So brow ridges tend to be more prominent in people exposed to testosterone, and shaving those and adding some fullness it's an art. I'm not a surgeon. And I will say, too, the majority of my gender patients don't get surgeries, period. And I think that's much more acceptable in this generation. There's thyrochondroplasty, which is a very fancy word for taking the little Adam's apple, the tracheal cartilage, and shaving it down. That's another secondary sex characteristic that can be very obvious to humans as male presenting. So you shave that down, and it cues the brain to think, okay, yeah, no. Voice surgery, controversial. There's sometimes it's helpful. Voice therapy tends to be the route that my patients go, and there's a wonderful voice center, Darlene Monda, at and that clinic is supposed to be wonderful. Some of my speech and language pathologists that have worked there have said that they just feel so loved there.
That's the one at Steinhardt?
Yeah, yeah. Breast augmentation, gender-affirming surgery. Some women get their breast augmentation done as a high school graduation present. And so saying, oh, we shouldn't do surgeries on 18-year-olds. Well, we do them when they're socially acceptable. So breast reduction also is done on cis women. Mastectomy, pectoral implants is another option. So I think those are self-explanatory. Hysterectomy, oophorectomy. My patients tend to just get elective hysterectomies and leave. The oophorectomy is the fancy word for getting your ovaries out. Tend to leave the ovaries in case they ever lose access to testosterone given the political climate, so that they still have some form of hormone-producing organs. Orchiectomy is testicle removal, and vaginectomy is vaginal removal. The things that I really deal with are the non-surgical options.
Yeah, I think that that's important to know. Obviously, at NYU, at the health center, we don't have an OR. We do not do any surgery there.
But they even when they're graduate students, whatever, a lot of my patients don't desire these surgeries.
Yes, I think that I've seen that a lot recently, too. It seems like a lot of people are interested in top surgery, both the augmentation or reduction or the pectoral muscles. You know, I think that that's going back to the presentation piece of this, right?
Outward presentation is much more important to a lot of these
You
students.
can't really see what's in somebody's pants or under somebody's pants.
But it's still a truly valid surgery. And,
of course.
And it's wonderful.
And also, what's comfortable? Because I know we had a guest on once that, you know, the binding is really like uncomfortable if you're doing that day in, day out.
Correct.
You know, and so like maybe it is outward presentation, but it's also their own like pain.
Correct.
It's
difficult to breathe. You can get rashes, all the things.
Right.
Yeah, it's been incredibly liberating and validating and affirming some of these surgeries.
Yeah, and that insurance can cover it, and some insurance doesn't cover certain things.
Correct.
So let's talk about what some of the non-surgical options are. You were mentioning.
I always, at the beginning of my first visit, show people the WPATH Standards of Care Guidelines, Chapter 12, because that is the medical interventions that I can do and what the guidelines are and what the rationale is. So hormone therapy, hormone blockers, those are the mainstay of what I can contribute to this conversation. But there's all these other things. We talk about social transitioning, body modification with facial hair removal, voice modification with Darlene Monda and her fabulous team. There's genital packing, tucking, chest binding. There's wonderful resources online that talk about other ways to modify your body in a way that more aligns with your identity. There's these amazing athletic trainers that I saw at the Fenway conference who help people lift weights and exercise in a way that will affirm their identity in a positive way. So much more beyond what medical providers do, but I do the hormone and hormone blockade.
Can you talk a little bit about the difference between the hormone therapy versus the hormone blockers? I know we don't want to get too far in the weeds of the medical, but
we don't do hormone blocking that's been discussed all online and politically now. We don't treat pediatric patients. We treat grown adults that can consent to this. And we don't give the GnRH inhibitors, the Lupron, that stops puberty from happening. What we do at the Student Health Center is we tend to give estrogen for feminizing therapy and spironolactone to block testosterone. When I say blockers, I usually mean spironolactone. Progesterone sometimes also acts as a blocker. Estrogen blocks a little bit. So that's on the feminizing side. On the masculinizing side, we give testosterone.
And there's lots of different forms of each of these medications.
Exactly.
Gels,
gels, injections, patches, and it depends on your health history and your risk factors. I find it really interesting, though, working in this field, that I give estradiol only to my trans feminine patients, yet we give conjugated estrogens, which are higher risk, to our cis women for birth control. And I just can't wait. I don't know if there's any economic incentive for estradiol-based birth control for cis women.
What would be the benefits of that?
So conjugated estrogens, which is, it was shown in the Women's Health Initiative that conjugated estrogens, equine estrogens from horse pee, absolutely increases your risk for blood clots and cardiovascular risk. There's the thought, and it's not fully been panned out, that estradiol, non-conjugated estrogens, is just I hate to use the term bioidentical, but it's the hormone that ovaries make, and it's FDA regulated, and we give it to menopausal women, that it decreases your risk for blood clots because there's way less byproducts that contribute to cardiovascular risk and blood clots.
Got it. Interesting. Okay.
It's safer to do patches than to take pills, we think. It bypasses liver metabolism, but, it exists. I've looked it up, the birth control that has estradiol, but there's no incentive to promote it in the U.S. so far.
Interesting. Wow.
Yeah, that is interesting.
We should shout from the rooftops.
And we're recentering it to cis women, but yeah.
As the non-medical person in the room, can you maybe share an experience with us, about someone that you started on feminizing or masculizing hormone therapy and how you saw them transform?
I love this patient so much. I am going to be so sad when she graduates this year, but she came to me 4 years ago, and she had been socially transitioned her whole adolescence and really came to NYU ready to start hormones. We had a conversation about, prior to starting hormones, might want to bank sperm because then you ensure a backup for if there's any fertility issues from starting hormones. And so she talked to her family. Her family was sort of supportive because she had already been out since she was 10. But they said, this is on you. If you want to do this, you have to pay for it. And so she got a job, and she worked for 6 months, paid for the sperm banking, came back to me in January. We immediately started the hormones, and it's been such smooth sailing. Sometimes I have to adjust hormones every 3 months and sort of get to the ideal transition levels, but she hit the levels at the, textbook medication. She came back, because I don't see her that often now because everything's sort of smooth sailing. She came back this fall and said, my mom and I were having this conversation. Was I ever making male hormones? Because I don't feel like I was. I don't feel like I was ever a boy. And I said, well, let's look. Because I did the baseline stuff before the sperm banking. She was making high, between the age of 18 and 26 is very high testosterone levels usually, and it's very challenging to suppress them. Very high testosterone levels and very low estrogen levels. So if a doctor were to just look at the labs, they'd be like, that is a cis male. But I just thought it was so powerful that both she and her mom were in agreement that she was never a boy. And it was beautiful. And the family had, over these 4 years, I sort of missed it because I was just seeing her for blood checks, had completely accepted this transition and celebrates it now.
I love that. Great. I don't think that's as common. I feel like maybe more so now.
Yeah.
But I really love that she had that kind of support from her family. Maybe not initially with the transition.
Not initially. They were nervous. And sometimes having meetings with parents and really discussing everything with them can be helpful. But in this situation, she and her family had to move at their own pace, but it was really pretty.
I think I would have expected, since she was socially transitioned at 10, that they would have been a little bit more accepting.
It's hard.
Yeah.
Especially in other parts of the country.
Oh, for sure.
And I think she came from another part of the country.
Okay. But still, even that's impressive for them. I feel like
100%.
For it to be from another part of the country and for them to be socially accepted. I think that's huge. Also, to sort of to have that kind of support, even socially so early.
Yeah.
I mean, again, taking the, steps to potentially alter, a little bit more, not necessarily permanent, but like taking
some of it's permanent.
Yeah.
Right.
It's a big deal. And
Right.
and I think that's that's one of the misconceptions, is that these students are doing this on a whim. And that's just not been my experience.
I was going to say, too, that I think that that's, I don't want to discount people who have lost family relationships. I think that that is very real, that in many, many places that people just completely disconnect contact from their families for boundaries for themselves. But I do think that more so in the last year or two, I have seen that the parents' concern is not that they don't want their child to have a gender that's congruent with how they feel. It's more of the long term, right? That
Exactly.
the saying
that they're
of like
doing something that they might regret.
Yeah, or that there's not enough research. We haven't researched this over the long term. What's going to happen to them when they would have been going into menopause, or all of these things long term? And I think that those are valid concerns. We should question the medical establishment all of the time.
Yeah.
but yeah, I think that that's hard. But that's almost easier for the students because they have that support, the social support.
I could go through, I've seen a bunch of patients, and my patients that come from other countries is a whole another level of resilience that is required of them. And then going back to those countries, it can be incredibly challenging. And I'm not talking about countries people might be thinking of. I'm talking about like Ireland, Germany. There's huge wait lists to get into gender-affirming care in certain Western progressive countries, and helping them to find care outside of New York is incredibly challenging.
So we've heard from many folks, both anecdotally at NYU and elsewhere, that sometimes going to medical offices are terrible experiences for gender expansive folks. People are still often dead named, which is not okay. And we are continually working on that. People are misgendered. They're not believed. People are told, oh, this other medical problem is because of your hormones, when it clearly is not. So I'm curious if you can share things that you do, other folks at the health center do to make the environment safe for folks to share their experiences. Are there things that you say to folks so that they know that you're sex positive, or you have more experience in this specific area?
Yeah. I mean, I wear a button with my pronouns. I have a pride flag on my stethoscope just to sort of indicate that maybe I'm okay. But I think the health system in general is not set up correctly. I struggle with this. I continue to work on getting better. We've tried really hard to make our clinic welcoming and use non-gendered language in our care. We still have more work to do. I let my patients know that my goal is to support them in their self-actualization from a medical perspective, but that I'm not in the position to tell them what's right for them. When I meet them, I openly admit at the beginning of the visit that I'm a white cisgendered woman, and how my goal is to not center myself in the conversation. My goal is to center them. I also let them know that I'm not coming this from a traditional pathological mindset. I tell them that they don't have to come to me with dysphoria and then tell me that the hormones are fixing the problem. I see this more as a partnership to treat gender incongruence. Going through a second puberty can be hard. I don't expect them to come to me and say they're cured of anything. I do share my previous clinical experiences, and I also share how I come to my decisions and encourage them to read my guidelines and think about the risks and benefits for themselves. As I said, I have them look at chapter 12 if they want to geek out and read the whole chapter. I like to think about all aspects of health. I also offer to have a family meeting, as I said, answer questions with them. I'm also pretty shameless about encouraging them to find their community. I refer all my patients to therapy, the other NYU groups, the Discord group, Tea Party, off-campus resources like the LGBTQ Center. The Liberation-Based Psychotherapy is a new place that I've been sending people to that they've had really positive experiences with. New York is a place filled with resources that are better than me. And so I try to just be as welcoming and trauma-informed as possible, and also stay out of their way.
I think that's important to note. But I also love that there are these small, subtle ways that you're also sort of indicating. I think one of the ways that, in counseling, I will always introduce myself and share my own pronouns.
Yeah.
And usually that, is like fine, and students like get that cue. But I've had like a couple students, this is more recently, like, why are you asking me that? Like, of course. And I was like, well, that's because you're cisgendered. And, you know, you want me just to sort of affirm that right away. But like, I don't know. And I don't want to like come into this space and assume. And if I happen to be, you know, meeting with someone who is, you know, identifying in a different way, then I'd rather center them and their comfort and space. Like as, you know, cisgender person, you're constantly centered and assumed. So like, I'd rather center someone else's experience. And you know what? Like, how much harm is it really doing to you to share with me your pronouns?
Right.
Yeah.
And maybe that will encourage them to start thinking about other people outside of that space.
I mean, I definitely like shifted the conversation and they were okay with it. They're like, all right, fine. But I think it's important. It's like these subtle, small ways that we're also like showing, hey, like it's safe here.
You mentioned trauma-informed care. What else does that look like in your practice?
So, you know, trauma-informed care, I love the concept of it. I don't think it was discussed enough in my medical training in the early aughts. I unfortunately have a ton of experience because I worked in underserved care. I worked at a homeless drop-in site. I worked with undocumented migrants. A lot of trauma in a lot of my patients. I like to approach my care with both humor and sensitivity. I tend to lean on humor sometimes if I can. I try to acknowledge the power differential in the room. I try to sit below my students on a short little chair while they're on the table and let them know that they're allowed to be in charge. And I try to ensure consent in what I do. You know, just listening to a heartbeat, I'm going to listen to your heart. I realized I wasn't warning people when I was going to feel their lymph nodes on their neck. That is such a ticklish, sensitive spot to go to someone. And so now I'm going to feel your neck. Is that okay? I apologize. I'm poking and prodding you, but I have to feel this. It's hard. Life is short. People go through a lot of trauma, and I think it's finally getting acknowledged and we're finally getting language for it. And yeah, I'm glad to be at a place that's at the forefront of thinking about these things.
Well, I'm also hearing, you know, as far as trauma-informed care, that you are as transparent as possible, whether that's with consent or whether that's with how you're bringing in like information, you're talking to them. You're also giving them a lot of empowerment and choice. And I think that's really important when it comes to like the trauma-informed.
I mean, that's one of the reasons why I love taking care of college students is there's such a collaboration that can happen. And I think it's fantastic. I remember in medical school, I had an OB-GYN that said, oh, you're going to regret that your patients can look things up on the internet and they don't just believe you. And I remember being really angry.
Yeah.
That knowledge is power, and even if they're looking up the wrong sources and the wrong things, like I want to hear what their ideas are, and I want to have that conversation. That's why I like family medicine and primary care. And I have the coolest conversations with my students from all over the world. I come home each day. My husband can tell if I haven't been working for a while because I get grumpy. I like to hang out with people and sit with their issues and hopefully make them laugh and go away feeling a little bit better.
That's great. But I also think you're creating a safe environment, right? And that collaboration, those are all like, and again, you're talking to someone who's very trauma-informed. I do trainings on this. And so those are like the key principles of trauma-informed care. So whether you're putting it in that frame, like you're setting them up to feel safe. You're not rushing them. Because I think so often we get rushed.
That's the thing is I don't get rushed like I got rushed at my previous job. And now that I'm in my mid-40s, I have way more experience. So I'm not concerned or nervous when I see something out of the ordinary. I'm used to it. And I can sit with my patients a lot longer than you can in the real world of healthcare.
Yeah. But that's also how you're unpacking the power differential, right?
Yeah.
Because I think if you're sitting with them, you're allowing space for them. They don't feel like, oh my God, they have so much more power. They have to go. I'm like being a burden.
Yeah.
Right. You're sort of sitting with them and you're allowing them to like have the space to ask the question. Because so much of my like healthcare is, I get so nervous and I forget everything.
You have to make a list and read everything.
Yep.
Yeah. Well, one thing I will add that you're bringing up that I guess one of the things that really helped me be trauma-informed, and I don't mean to blow my own horn, but It's a personal health experience. I had a tubal pregnancy that almost killed me, and I diagnosed it when my OB missed. Because it was a complicated. Like, she kind of missed it, but I understood how she missed it. But it was still really awful to be like, no, this is wrong, and to be called out and saying, you're wasting my time. Why are you bothering me? And me saying, no, I think something's horribly wrong. I have to go to the hospital. And being a patient, I think, really, really helps doctors be better doctors. And I bring it up a lot because I get a ton of patients that have had medical trauma. And, you know, they'll burst into tears when I walk in the room. I've said nothing, but I'm the doctor, and I walk in, and it's just too much because they had a chronic disease when they were 13, and they had all these doctors coming in and all these teams and these needles and the poking and the prodding. And saying, you know, I was a patient too, and I know how awful hospitals are. There's a reason why I don't work in a hospital. Right?
Yeah. But I think that's really, really beautiful because you understand and you're like empathizing with them in that moment.
Yeah.
And again, that goes back to trauma-informed care.
Yeah.
That empathy. So you're just the embodiment, and you're just...
Tell my kids that. They're like, Mom, you're so mean. Dad, that's, you know, I said I'm the masculine woman. I'm the dad in the family, and my husband is the mom, and he's the caring patient, will do the homework with the kids. And I'm like, ugh. You don't know how easy you have it, kids. Like, get it together. So I'm actually not very trauma-informed with my own children.
That's a little different, right? You gotta practice.
Pull up your big girl panties, girls. Let's go.
Yeah. So you're flipping the gender script.
Yes.
At home, right? And that's okay because that's just part of who you are.
Yes.
So it's not masculine or feminine. It's just like part of you.
Yes.
So we've talked a little bit about the politicization of medical gender care. I'm curious if there are other common misconceptions you've heard about the work that you do with gender patients. I'm sure you could write a book.
No, I'm in a very protected space because I'm in New York. And, you know, at one point in my career, I thought I was going to be a country doctor and deliver babies and do everything. And then I realized I don't like hunting. That doesn't bring me, I'm not like-minded. I'm with a ton of like-minded, supportive people. I think this issue has become profoundly political, and I think there's a ton of misinformation there, just as there's always been a tendency for people to criticize, ostracize, and scapegoat the most vulnerable groups to maintain power. I'm consistently meeting with my gender patients and telling them to stop bearing witness to what's going on outside of New York because I will bear witness for them. I have the capability to bear witness for them, and they, as a young student going through a transition, should not have to bear the burden of all of these attacks. I don't know if they'd believe me or do it, but I tell them to watch stupid cat videos instead of the news. So the biggest misconception I run into, and I've mentioned this already, is that patients do this on a whim and they're not properly thinking through the consequences of their actions. My patients are incredibly thoughtful and incredibly emotionally intelligent. I ask them really sort of, what are your goals? How do you see gender? What do you want? And they are so literate, so much more literate than previous generations, so much more thoughtful. I'm in awe after meeting with them, and they've thought about this. They know about this. I'm thankful for the internet, too, for them having community, even in the middle of nowhere America, so that they know what is going on and what they want and where they want to go.
There can be good things and I think challenges as well with the internet.
Yeah.
And that's one of the good things. I think some of the challenges is that you do get sort of looped into that, like,
what did
harmful.
Reddit tell you?
Yeah.
What did Reddit tell you about how you had cancer? And I am happy to bring it up.
Yeah. I think one of the things that I heard you say that I want to bring into like the misconceptions is that like you refer people to counseling. And I think that that's great, but I think also that it's not like as a result of pathology, right?
Correct.
And so it's more of like you need support. You know, we're on the counseling side really here to sort of help you navigate whatever's going on in your life, whether it's related to, you know, the gender-affirming care or if it's something related to like school or something different or anxieties or navigating like the family stuff. Because I think sometimes I think it's maybe a little bit, you know, different generationally, the myth that, you know, oh, well, like you need therapy. And not everyone needs therapy if they're
Yeah, until
Right.
2017, WPATH required therapy prior to starting hormones, and they've moved more to an informed consent model because we do a lot of life-altering things in medicine to people, and we inform them and obtain consent. And so I am a strong believer in the informed consent model, but I also want to make sure that my patients receive all the fantastic resources and support that they can, because it's not easy. And it's not easy in this time, especially.
I mean, I'm a firm believer that everybody should go to therapy.
I am too.
And
I am too. I mean, especially because that's my job.
yeah. But also, I agree with what you're saying, that it should not be, you should not
There's no
go to
hoops
therapy
to jump
because
through.
Right.
Yeah.
there's something wrong with you if you
Yeah.
are thinking about starting hormones or having surgeries for gender. I think that that's a very important distinction to make. That, the counseling and wellness is there to help with all of the changes that might be coming, or the transitions of life and
family
and
issues, exactly.
but
And
not
school.
a pathological problem. Yes.
And midterms,
Yeah.
All of
roommate
the things.
issues.
Yeah.
But I remember that being something
Yeah.
that I think was a misconception. I don't know for me, because I work in this field,
Yeah.
but I think some of the things that I've heard, and I just wanted to unpack that, because again, that was
Yeah.
way back earlier in the session or in what we were talking about, but just wanted to like make sure that listeners really sort of heard that it wasn't around like needing it for a medical purpose, but needing it as like just a supportive way of like navigating life in general. Because again, everyone can use some therapy or some support. Any other like myths or misconceptions?
There's a lot of I think engaging some of the misconceptions are not productive.
Yeah.
Because I think there's a complete push to just ostracize this tiny vulnerable group, to rally everyone with fear to gain power.
Yeah.
And I think the people that I deal with on a one-to-one basis, we know what's going on, and we ensure that there is informed consent. We ensure that everyone understands the risks and benefits of any treatment that I do as a physician. I also get that they're college students and they're young, and I'm a mom, and so sometimes I fall into the role of being a little paternalistic and saying, are you sure you want to talk this out? This is what I recommend. And I've been incredibly satisfied with the level of care that we provide.
That's great. And I agree. Sometimes talking about it isn't really helpful.
It's like creating a false binary, right? Like the vaccine movement, like you don't need to interview the anti-vaxxer to get the right facts. I understand. I mean, and we said earlier, this whole idea that that's a misconception, that testosterone is going to make you a jerk. I do joke that I'm turning these sweet people into white men, and do they really want that? But they're not. They're them.
Yeah.
And that is a wonderful person. And we could use to have more of these people on this planet. A lot of my gender patients are going through some serious depression right now with the way the world's going. And the empathy and the sensitivity that they have is what makes humans fantastic. And I don't want them to feel unwelcome in this world.
And if someone is new to the university or is interested in starting or transitioning their gender medical care to the Student Health Center, what does that process really look like? And what are some of the services that are and aren't available at the Student Health Center?
Can I throw this to April?
Yeah. So we did talk a little bit about that. Obviously, we are not a hospital with an operating room, so we can't do any of the surgical procedures. And the providers at the health center are focused mainly on prescribing hormones. But so starting from like the top of the process, we about a year and a half ago changed sort of the way that students can get connected to medical gender care, not because we were trying to create hoops or gatekeep, but because we felt like students were unsure of the process. And so, and were kind of scheduling themselves in the wrong place and not getting enough time. And like Dr. S mentioned, we really try to prioritize time. These visits are longer with the providers. And so wanting to make sure that students are actually getting the care that they deserve. And so we created an option. Students can make the appointment on the portal, so the SHC portal. They can go and they can select the medical gender care, and that they fill out a form that gets dumped into a kind of a collective mailbox that the care coordinators, who myself, I'm a care coordinator, as well as we have a couple others on staff, and then one of the care coordinators will reach out and schedule like a 1-hour intake, and that person, during that intake, the care coordinator is collecting a lot of information that will then be kind of cut down the time that the provider would have to ask some of those general questions. And then that means that by the time they are able to meet with the provider, which is a quick process, it's not like it takes 2 weeks to meet with the care coordinator and then 2 more weeks to meet with the provider. We have a lot of...
It could be within a few days.
Yeah, it could be within a few days. And there's designated spots on our medical schedule for these specific types of visits. And so we're really trying to prioritize getting people in as quickly as possible. But then when they get to meet with the provider, the focus is specifically on what Dr. S said. What are your goals? What can we do to help you attain those goals? And so really just kind of focusing on this person's individualized medical care in that visit, as opposed to kind of asking all of the intro questions, kind of social history questions. And so it's meet with the care coordinator, then meet with the medical provider, do a virtual visit, then an in-person visit with the medical provider. And again, this is all kind of based on whatever the student is interested in. If somebody's just interested in top surgery, but they don't want hormones, they don't need to meet with the provider necessarily to get labs drawn or anything like that. It's really kind of specific on what the student is really looking for.
Yeah, I just had a patient that just wanted top surgery, and it was a virtual visit, and we saw each other to do the physical for the preoperative clearance and to get that. Surgeons still require letters for gender surgery, whereas you don't need letters for a hip replacement or a cisgender breast augmentation, but our gender patients require letters, and so they have to meet with, and I'm happy to provide those.
Our therapists are also able to, and it depends, like we kind of alluded to some things being covered by insurance and not, and the NYU Health Plan, Wellfleet, has done a great job in the last couple of years. They could still do a even better job, but really kind of trying to delineate which services of gender care, medical gender care, are covered or not. And I think one of the good changes that was made was for top surgery, somebody needs only one letter, and it could be from a therapist or a medical provider. It doesn't have to be one of both, which I think was a change. So if somebody has a therapist that they've been seeing for a long time, they don't have to just come and schedule an appointment with us to be like, hey, can you write me this letter to
And is that Wellfleet only? Because I know we have students who have
so I'm talking Wellfleet specifically.
Here's a cool one. Kaiser covers fertility preservation prior to gender affirming, even if you're a assigned female at birth. So I had a patient from California who had already preserved their oocytes and started testosterone by Kaiser, and it was a 2-second visit for refills.
Yeah, so insurance really matters.
Yeah. Well, and California has a state law that maybe we should enact that fertility preservation should be covered.
So in that
Wellfleet
sense,
does cover
a
tiny amount of fertility preservation.
Yeah, Wellfleet is better than some.
Right.
Not as good as Kaiser. So yeah, it's definitely, we can only speak to the Wellfleet specifics because that's what a lot of the students that we see have Wellfleet, but the care coordinators are happy to meet with anybody with any type of insurance. So that's somebody that's never been on hormones, never seen a provider for medical gender care, easily can get connected to our providers and get started on that process. We also have a lot of students that come, like you're talking about, the student coming from California that had already preserved the eggs and started on the hormones and just needs to transfer their care to the student health center. And so we can do that as well. And so just really trying to, if you just need a place to get new prescriptions or something like that.
But I don't want to discount having a care manager is magical, because it's another point person that you can reach out to get support and get questions answered, because I have thousands of patients and I love to obsessively keep my inbox empty, but some questions I can't answer, and the care coordinator is just so wonderful to have as an advocate for you and to help you navigate this very confusing healthcare system.
Yeah, and we definitely are willing to be right there with you. We can call insurance companies with you, set up referrals, kind of just the healthcare system is confusing in this country for me as a medical provider too. For really everybody. And so really just having somebody, we don't want to do all of the things for you, but we will definitely hold your hand and help you get through it because it's a very complicated system.
And, I just had a patient this week who is worried about failing a class, and I was able to connect them to a gender patient because it's hard to be a gender patient right now. And, they had just spent a semester abroad where it was harder to be a gender patient. And I was able to connect them with Student Success, which is an awesome program, too. And that's something the care coordinators can help with. The Moses Center, Counseling and Wellness, and academic advisors.
I think that that's a good thing to point out as well. Like, NYU is a huge place, and it's really easy to not understand all of the resources available. And so I think that that's also the care coordinator can help students get connected to medical resources, but also the other resources at the university. And that's kind of one of the things that we wanted to highlight as well. And
I think I need a care coordinator.
yeah.
I know. We
all could.
Yeah. And you mentioned Chris Woods earlier.
Yeah.
Definitely shout out, plug the LGBTQ Center at the university. There's so many great resources there to both clubs and groups. And
there's a gender group that Tiffany runs too that she does every semester.
I think they have 2 this year. Or this
Yeah.
semester, 2 groups.
That's awesome.
Yeah.
Oh, I'm psyched that it got expanded because every once in a while I'd be like, I can't do Mondays. And I really want to do it.
Yeah.
So definitely reaching out and getting connected is really helpful in whatever way. Like, and again, sometimes you might get connected to the LGBTQ plus center first, and maybe they can, shout out all the great services here and get people connected, or vice versa, or in many different ways. But we'll include some links.
Yeah, I know that we just did like a huge resource dump, so
that was a resource dump, but it is online. To
links.
Get care, you go online, you fill out a form, and you'll get contact.
And if you...
So you don't have to call and speak to a human, because I know that's hard.
I think it's generational as well.
Generational.
Folks don't like to call.
Please call.
If you type in Gender-Affirming Care NYU into Google, we are now above NYU Langone, and that is the first link that's there.
We have more providers.
And that has all of the information there as well, if you don't want to go click on all the resources.
Yay.
Yeah. Anything else that you feel like
I don't think so.
people should know?
Yeah.
No, this is really fun. Thank you, guys.
Yeah, well, thank you. I feel like I learned so much. I kind of just sat back. I was like, oh my gosh, this is really informative.
It's an awesome... One thing I'll add is that it's not rocket science to be a gender-affirming care provider, and it's a crime that it's hard to get access to it. And I'm happy... And there's tons of resources. I'm happy to speak to any provider and show them how easy it is. And I think it should just become part of primary care.
I think it's similar to trauma-informed care. Everybody should be doing it, but every doctor should be doing it.
Right. It's
no matter where you land in like your field of specialty.
Right.
Yeah.
Well, and that's... we could have a whole nother conversation about this. The term gender-affirming care should really just be care and how we provide care. And like that's why we kind of try to...
holistic care.
Medical gender care, specific being like the surgeries and the medications and whatnot. But gender-affirming care should be provided everywhere.
Well, that's what I say about
patient.
trauma-informed care.
Exactly.
I say it should just be care.
Yes.
Like, it should just be care. Why are we, like,
standard.
everyone? Exactly.
Yeah.
So I completely am on board with that.
Yeah.
But thank you so much for joining us.
Thank you for having me.
Thank you. If you have questions about the podcast or anything we talked about today, please feel free to reach out to us at goodsex.podcast@nyu.edu. This email address is monitored during business hours and may take 3 to 4 days for follow-up. We are definitely open to critical and thoughtful feedback, as we didn't cover everything in this episode and might have said something that was inaccurate or that had a negative impact on someone. If you have questions about your sexual health and are an NYU student, you can connect with our Student Health Center sex expert at sexpert@nyu.edu or schedule an appointment through the Student Health Center portal. Look at our show notes for additional information and resources, including organizations, articles, books, and videos.
If you have urgent mental health concerns, safety issues, or you are worried that someone might have caused harm to you, or that you might have caused harm to someone, then you can contact NYU's Confidential Wellness Exchange at 212-443-9999. Chat with them using their mobile app or email them at wellness.exchange@nyu.edu. For anyone, NYU or non-NYU listeners, you can call the National Sexual Assault Hotline at 1-800-656 4673, the National Domestic Violence Hotline at 1-800-799-7233, or the National Mental Health Hotline. Simply dial 988 from anywhere in the U.S.
Thanks for listening, and tune in to our next episode where we continue to talk about good sex at NYU. Subscribe to the podcast to hear all of our quickies and interviews with NYU community members. Thanks to our content contributors for this episode, Bernadette Kerr, Alyssa LaFosse, Dr. Dominic Vaini-Amisa, Zoe Raguzios, and to our health promotion team, Anna Genova, Jenny Mellum, Parade Stone, and Arna Dixit, and to Gotham Studios and Karen Ortman.